The focus of this part of our lecture in gastrointestinal system disorders is on liver pathologies. So what we'll do in this time together is take a look at hepatitis A, B, and C. We'll talk about how ethanol, alcohol metabolism leads to liver dysfunction. And then from there, we'll talk about cirrhosis and the complications that are associated with cirrhosis and therefore parenchymal liver disease. We'll end our discussion with talking with a comparison, if you will, of cholecystitis and cholelithiasis, very commonly occurring. As we think about liver disorders themselves, I think it's helpful to do some differentiation between acute and chronic, as well as some of our assessment parameters, and then differentiate between hepatocellular and cholestatic pathologies, just to do a quick introduction. So we know that liver disorders can be due to acute issues, or it can be due to chronic issues. For example, one of the acute liver disorders, causes of acute liver failure, is acetaminophen overdose. This is something that we see a little bit more in England than we do here in the U.S., but is a very common etiology of acute liver failure. With chronic liver failure, frequently this is associated with disorders of liver metabolism, and especially with chronic liver failure, and there are different pathologies, we'll talk about some of them, but with chronic liver failure we are concerned with protein synthesis as well as abnormalities that will occur outside the liver as a result of the liver failure itself. So a couple of the big things we think about in terms of protein synthesis is we think about what the liver actually does. The proteins that it synthesizes for our clotting factors as well as for our immune globulins. That then leads us to how would we assess liver disorders. The most common way we assess liver disorders is through measuring the liver enzymes. The two most common that we use are AST and ALT. AST is aspartate aminotransferase. ALT is alanine aminotransferase. And these are helpful in differentiating between some of the more common disorders that you'll see in liver pathology. So for example, if you hear that someone has a transaminitis, what they mean is they have a lot of inflammation in the liver, and as a result, their AST and their ALT, as well as their alkaline phosphatase and bilirubin, are elevated because of inflammatory processes within the liver. The other clue that we frequently use as it relates to AST and ALT is to kind of help us differentiate between what the pathology may be due to. So for example, AST, you may think about that as a social disease, and so we look for someone who has been abusing alcohol, and you may also look for other tissues that are affected like the heart and the muscle, because AST can elevate in other tissues. ALT is more specific to liver cellular function itself, so it's primarily in the liver. So you don't see ALT elevated in other tissue diseases. As I mentioned previously, as we assess the liver function, it's important to look at synthetic function, the coagulation factors, as well as those proteins that are important in our immune system, our immune globulins. A fourth critical piece as we look at liver pathology is the potential impact on liver pathology on metabolizing drugs. We know that the liver is a primary site of drug metabolism. Kidneys do the excretion, liver does the metabolism. So if someone has an inflamed liver or who has liver cirrhosis or liver failure, we have to be very careful with drug dosing because they're not going to be able to metabolize the medicines very completely or very well. And then last but not least, we know that because of what the liver does, not only in its metabolic function, but also its conversion of pneumonia, we have to be very alert to the effect of liver failure and cirrhosis on the neural system and our brain function as we assess our patients. The last way we look at most liver disorders is to put them into two pretty big buckets of cause. And so we look at hepatocellular versus cholestatic pathologies. So when we look at a hepatocellular injury, this is where you'll see elevations of AST as well as ALT, because remember, the cells are being altered. This is what you might see in a severe hepatitis, an acetaminophen overdose, Wilson's disease, which is a copper storage disorder. With cholestatic pathologies, the biggest thing we're looking for are biliary obstruction, and we'll also see this in cirrhosis, because it's going to cause difficulty with stasis. So when we look at cholestatic processes, we are going to consider alkaline phosphatase and GGT. With alkaline phosphatase, that goes up because this is the enzyme that breaks down protein. Most of it comes from the liver, but again, it also comes from bone, intestines, kidneys. GGT, or gamma glutamethyltransferase, is more specific to the hepatobiliary system. And it's helpful, it is sensitive, but it is not specific, because other muscles can elevate the GGT. However, if you combine an elevated GGT with an elevated alkaline phosphatase, it is you increase the sensitivity and specificity to cholestatic liver disease. As we identified previously, this is frequently due to an obstruction in the biliary tree, cirrhosis itself, and can also be due to hepatitis, especially with alcohol ingestion. So let's take a deep dive now and let's talk about hepatitis. We know that the hepatitis virus comes in three general, really big types: hepatitis A, hepatitis B, and hepatitis C, all three of which are viruses. Now, it is important that you be able to differentiate among them based on their transmission as well as key laboratory data. And we're going to go over those labs, hopefully to help understand the virus and how it leads to immunity versus active and chronic infection. So when we look at the keys of determining those lab data and immune status, we look at IgM as well as IgG. Remember that IgM generally indicates an acute infection, whereas IgG generally indicates immunity. So we know that those are going to be important. But we also want to look at, especially in hepatitis B, surface and core antigens, because knowing our surface and core antigens as well as surface and core antibodies can really tell us what's going on with the virus. Let's start with hepatitis A. We know that hepatitis A is transmitted through a fecal-oral route and has about a 4 to 6 week incubation period. Now, antibody to hepatitis A, or anti-HAV, which is antibody to the hepatitis A virus, usually develops within about 4 weeks. So during that time, you would see a shift from IgM to IgG if the individual is responding appropriately. Hepatitis B is transmitted through serum and sexual body fluids. We also know that hepatitis B can be transmitted perinatally, so that would be important if you're working with hepatitis B positive moms. The incubation period, as you can see, is a bit longer than with hepatitis A. And although the average is about 6 to 8 weeks, it can be as long as 6 months. So just because someone was exposed, a couple of months ago, don't completely rule out hepatitis B as a possibility. So then when we look at hepatitis B, we are especially interested in antigen as well as antibody, and we also are interested in IgM and IgG. Let's take a first look at the antigens, and you can see the antigens listed there. Hepatitis B surface antigen is usually the earliest indicator of hepatitis B. Hepatitis B core antigen is actually the best indicator, and we use that one a lot when we are looking at our hepatitis panel. Hepatitis B envelope antigen is antigen on the outer rim of the envelope of this virus, and this is when the patient is most infectious. If the hepatitis B envelope antigen persists, this indicates chronic infection. Now, just as we can have surface, core, and envelope antigen, we can also have antibody in those same areas. So you can have a surface antibody, a core antibody, and an envelope antibody. And these are also very important. Now, there are two ways that antibody is usually described in both the literature as well as in our labs. You can see it the way, as you see it here, you can see that it is HB and then the small letters, antigen or antibody. Or if you do with the antibody, they may call it anti-hepatitis B with the little s. So they'll put the antibody a little bit later. We'll take a look at those. Once again, we're looking at both IgM as well as IgG. So with hepatitis B, a hepatitis B IgM would tell us that this is an acute infection, more likely early on, and IgG is important because we are going to look at whether or not an individual has any IgM or IgG. IgG, this anti-surface or core IgG, may be present in both chronic as well as resolved infection. But the important concepts here of going through all of that is, where's the antigen? Where's the antibody? Do they have IgM or do they have IgG? Remember, IgM is early infection. IgG either indicates chronic or, in the case of hepatitis B, a resolved infection. Hepatitis C, before I go to hepatitis C, my apologies. With hepatitis B, I keep talking about this core and surface, and the reason that's important is because of the structure of the virus. This virus has a viral core, which is where you'll see the antigen and the antibody, as well as the surface, which is that lipid envelope that can have both antigen and antibody. Let's turn our attention now to hepatitis C. Hepatitis C, like hepatitis B, is transmitted both through serum and sexual body fluids. Incubation period is the same as hepatitis B, and like hepatitis B may last, that infectivity, or incubation period rather, may last longer than the average 6 to 8 weeks and may be anywhere from 5, again, up to 6 months. What we look for in, when we're looking for the presence of hepatitis C is we're looking for antibody to the hepatitis C virus. We're looking for IgG. One of the ways we test for hepatitis C, and the most important way, is by looking for hepatitis C viral RNA. And we use the same basic kind of test we used for HIV, that PCR. But what we need that test for is to confirm a current infection. And so that's why that hepatitis C virus RNA becomes very important. The other reason it's important for us to have that RNA is that helps us with the genotyping. because we need to know the specific genotype of their hepatitis C for their treatment. We know that there are about 6 different genotypes for the hepatitis C RNA. In the U.S., the most common are genotype 1, 2, and 3, and those are the most common that you'll see in the U.S. Unfortunately, the genotype does not predict the outcome of the virus itself, whether or not it becomes chronic, whether or not it resolves, whether or not it causes additional damage. We also know that individuals who are hepatitis C positive tend to be co-infected with hepatitis B as well as HIV. We also know that the risk of developing chronic liver disease is highest with hepatitis C, and actually hepatitis C is the most common reason for liver transplantation. We also know that individuals with hepatitis C have a greater risk of developing liver cancer. Hepatitis C, like the hepatitis B virus, has a core protein, but it actually has 2 envelope proteins. And depending on their envelope protein would signify whether or not the virus is more likely to mutate, the E2 being more likely to mutate. Now, the interesting thing about this virus is the virus doesn't kill the liver cells directly. The liver cells actually get killed by the immune response. In the immune response to the hepatitis C virus, we have both CD4T1 helper cells and CD4T2 helper cells. Those individuals who have more CD4T1 helper cells are more likely to clear the virus. Individuals with a predominance of CD4T2 helper cells tend to develop a more chronic form of this disorder and develop chronic hepatitis C. Now, I promised you that we were going to take a look at some of these labs and kind of noodle our way through this. So we'll take a look first at hepatitis A. With hepatitis A, we frequently look at our immune globulins. So you know that someone has a hepatitis A, and they have hepatitis A IgM negative, but their IgG is positive. So what's their immune status? They are immune, and they're either immune from having the infection or due to immunization, because remember, their IgG is positive. So if a patient is IgM negative as well as IgG negative, what's their immune status? They got nothing. They have no immunity. Now remember, as long as someone has a hepatitis A IgM positive, they are infected. Because remember, IgM indicates active infection or acute infection. IgG indicates immunity. Okay, now let's do hepatitis B. Remember, we're going to use our surface antigens and our surface antibodies. So you have a patient who has a negative hepatitis B surface antigen, but their core and surface antibody are positive. So hepatitis B surface antigen is negative. Their surface and core antibody are positive. What's their status? They are immune, and their immunity was conferred by actually having the infection. They have antibody on both surface as well as core. And you know they're not actively infected because their antigen on the surface is negative. So antigen surface is negative. Their core antibody is negative. Their surface antibody is positive. So what's their status? What is their immune status? They are immune, but they've gained their immunity due to their vaccination. And you can see that because their core is negative. In the previous example, their core was positive. So they actually had the infection as opposed to being vaccinated. Let's look at one more. Surface antigen is positive. Their IgG core is positive. And their surface antibody is negative. They are chronically infected. Now, you've got a positive surface antigen, so that's giving you a clue that something's not right here because they've got antigen present. And remember, or if you go back, we talked about that the core, that IgG could be positive both in chronic as well as resolved infection. And of course, the fact that their antibody is negative tells you that they've not developed any antibody to this. So this is a chronically infected individual. I hope that was helpful. When we think about the manifestations of hepatitis in general, so we're going to look at all forms of hepatitis kind of together, we know that we're going to be concerned with those elevated liver enzymes because this is hepatocellular, although it could also be problematic. We're going to look at an ALT usually being higher than an AST. So the alanine is going to be higher than the alanine would be higher than the AST. You just figured out I couldn't come up with the long name for AST, didn't you? All right, so phases of infection. Like so many of the infections that we've talked about, there are going to be some phases, but we can put a few additional characteristics or define these a little bit better. So the incubation period, as we talked about, for hepatitis A tends to be about 30 days, about 4 weeks or thereabouts. Hepatitis B could be up to 6 months. And HIV, though the average is 1 to 2 months, could also be much longer. In the prodromal phase, this is usually about 2 weeks after their exposure until they become jaundice. The likelihood that someone is infectious in this prodromal phase is going to be very, very high because this is when they're replicating that virus quite a bit. In the icteric phase, even though we call this icteric, they may or may not be jaundiced. Now, you're generally going to see icterus or the jaundice in hepatitis B and hepatitis C. And the variability on the jaundice is highest in B and C. They may have symptoms of specific illness, so they may have elevated temperatures, lethargy, all of those pieces. The bilirubin may be elevated, and it's questionable whether or not their prothrombin time might be elevated. I wouldn't depend on that a lot because it's extremely variable. But during this icteric phase, this is when the body the liver cells are being especially affected by the virus. During the recovery phase, this is when they become post-icteric, and liver enzymes begin to fall back to within normal limits. We also know that during the recovery phase, while they may recover from an acute infection, they may have a chronic active hepatitis and thus become a carrier of the hepatitis. So that's why we want to always look for their IgM, and we want to look at the status of their antigens as well as their antibody status. So let's move then from hepatitis, the inflammatory stuff, and let's talk about cirrhosis. Cirrhosis is also inflammatory, but not from a viral infection causing the inflammation. The inflammation is due to other disease processes, which could be liver dysfunction, disease itself, or could be due to alcohol or ethanol. But cirrhosis itself is represented by inflammation and fibrosis, frequently related either to hepatitis, as we just talked about, that end part of the hepatitis, or to alcohol. And alcohol, it's usually chronic alcohol ingestion. So let's talk a little bit about alcohol and livers. We know that the liver is very important in metabolizing ethanol. Ethanol and alcohol, essentially the same thing. Ethanol actually metabolizes to acetaldehyde, but it has to be metabolized by 3 enzyme systems. One is alcohol dehydrogenase, makes sense, that there's a specific, we've identified a specific enzyme that does this. We know that the cytochrome P450 system is important in alcohol or ethanol metabolism. Remember, cytochrome P450 is one we talk a lot about with drug metabolism, as well as catalase, which forms NADH. Now, there are different forms of what happens within this liver, and so let's kind of walk through the different forms. First is alcoholic fatty liver disease. And what happens in alcoholic fatty liver disease is, once again, you have ethanol metabolism, and you have the deposits of triglycerides because of an increase in lipogenesis, a decrease in fatty acid oxidation, and therefore a decrease in fat metabolism. So individuals may develop an alcohol-related fatty liver disorder, and the nidus is their chronic ingestion of alcohol, and the metabolism, the way that their liver is just constantly having to metabolize the alcohol. But alcoholic fatty liver disease is all about triglycerides and poor fat metabolism. With alcoholic hepatitis, that's the inflammatory process. And so they're actually, and we're not talking about A, B, and C. We're not talking about the virus. We're talking about the alcohol causing an inflammatory process within the liver. And then last but not least, the one that we probably have the most knowledge about, or the one that we talk about the most anyway, is alcoholic cirrhosis. With alcoholic cirrhosis, this is due to the negative effects of alcohol and the metabolism of that alcohol to acetaldehyde. With the metabolism of the acetaldehyde, which is produced by partial oxidation of alcohol by that alcohol dehydrogenase, this then leads to lipid peroxidation. It leads to then oxidative stress. With that lipid peroxidation and oxidative stress, you begin to lose the cellular cytoskeleton, which will then, remember, once you lose that structure, that cytoskeleton, you're going to have alterations in cellular metabolism, and you're also going to have dysfunction of the mitochondria. So as a result then, the cirrhosis then begins with some scarring, and you actually have nodules that form within the liver. These nodules continue, the scarring and the nodular formation continues to a fibrotic process. Now we know that fibrosis isn't functional, and as a result then, with this cirrhosis and this fibrotic process, this is going to be associated not only with poor blood flow, but also impaired biochemical function of the liver. In addition, in addition to what's happening in the liver itself, we also have additional toxic effects of the alcohol. So what happens with all of this alcohol that is present in the system, the GI bacteria, the bacteria, those endotoxins of GI bacteria are always throwing off, begin to translocate. They begin to move outside of the GI tract. This causes, within the liver, causes injury and inflammation. This injury and inflammation causes necrosis and collagen formation, leading to additional fibrosis and scarring. So I guess, if nothing else, we could say alcohol, bad on liver. Further inflammation, evidence that especially alcohol-related cirrhosis, but any kind of cirrhosis, leads to additional complications. And although the process of the cirrhosis is in the liver, it's affecting other parts, either within and primarily within the GI system, but not only within the GI system. And there are 4 complications, and a little bit on the 5th, that we'll talk about. So we'll talk about portal hypertension, we'll talk about ascites, hepatic encephalopathy, jaundice, and then we'll talk a little bit about the coagulopathy just as a reminder. So with portal hypertension, this is on the venous side. And on the venous side, there is a lot of resistance to blood flow, and that makes sense. Remember, you've got this fibrotic liver, this cirrhotic, fibrotic, changes in the vascular system that is going to cause resistance to blood flow. This happens both inside the liver because of the cirrhosis, so it's intrahepatic, but there are also outside of the liver or extrahepatic effects. So portal hypertension can also cause right-sided heart failure. Now, one of the biggest things we are worried about with portal hypertension is that this may result in esophageal varices. Now, varices are strictly defined as weak areas in the venous vessels. So when you look at these esophageal varices, one of our concerns would be the risk of rupture. So let's think about how that happens. With esophageal varices, you have an increase in the portal pressure. And this portal pressure, remember, has been increasing with the progression of the cirrhosis itself. With this increase in the portal pressure, this puts increased pressure on the spleen. The spleen then enlarges. And as the spleen enlarges, you have additional pressure in that same part within the body, and the vessel pressure in the portal system continues to go up. As that pressure gets higher and higher and higher, that increases the risk of those esophageal varices, those outpouched, weakened areas that have developed because of the high pressure. As it continues to rise, the risk of rupture increases. The other thing that's very interesting is this whole idea of the varices bleeding, and with a variceal bleed, frequently these bleeds are precipitated by an infection in a lot of patients, and the infection could be an upper respiratory, a pneumonia, a urinary tract infection, could be as extensive as sepsis. So just being aware that if your patient has portal hypertension and develops an infection, they are more likely to have an esophageal variceal bleed than if they were not infected. A second complication of cirrhosis is ascites. So what happens with ascites, once again, you've got the cirrhotic liver, fluid begins to collect in the peritoneal cavity. And this is a complication of either the portal hypertension that we just talked about, but it could also be due to that right-sided heart failure, that extrahepatic effect. And of course, we know that it can happen in nephrotic syndrome as well as anyone who has a very low level of serum albumin. I apologize on your set of slides for my typo. The most likely cause, for lack of a better phrase, of this ascites is splanchnic vasodilation. Now remember, splanchnic are, when we use that word, these are the visceral organs in the abdominal cavity. So the blood supply to all of these organs in the abdominal cavity, you've got this dilation going on. As a result of this splanchnic vasodilation, the systemic vascular resistance decreases. Now, you've dropped your systemic vascular resistance. That then is going to stimulate the renin-angiotensin-aldosterone system, and that says, hey, bring back more salt because I have no vascular resistance. With that, at the same time that you have a stimulation of the renin-angiotensin-aldosterone system, you will also increase the amount of antidiuretic hormone. Remember, this is back to fluid pathology. As a result of the stimulation of the renin-angiotensin-aldosterone system, as well as the increase of antidiuretic hormone, this leads to fluid retention and then transudation of the fluid into that peritoneal cavity. Because remember, water's stupid. It's going to follow that path of least resistance. Now, interestingly, when you have this fluid in the peritoneal cavity, it can actually lead to peritonitis. So if the fluid can either be sterile or it can be infected. It doesn't have to be infected to cause a peritonitis. We also know, though, that there can, because of all of this fluid and because of translocation of bacteria into this area, your patient with cirrhosis who has ascites may develop a spontaneous bacterial peritonitis. Individuals who have recurrent spontaneous or frequent episodes of spontaneous bacterial peritonitis have a poorer prognosis because this does increase mortality. A third complication of cirrhosis is hepatic encephalopathy. This is what we see in the neurologic impairment, and it's the neurologic impairment from accumulated undetoxified GI toxins. So really what we're looking at are these GI toxins, the cytokines, the serotonin, the tryptophan. I know that's what made us sleepy after Thanksgiving, as well as ammonia, because the liver plays an important role in breaking all of these things down. Ammonia is especially challenging. Ammonia metabolizes to glutamine in the brain, and when it metabolizes to that glutamine in the brain, it interferes with neurotransmitters. Now, what's important, again, we always look at ammonia levels in someone who has cirrhosis. However, we need to remember that those ammonia levels do not have a direct correlation to the extent of the encephalopathy. So what this means is the level of ammonia does not predict the extent of the encephalopathy. You'll see patients with very high levels that are not encephalopathic. You'll see patients with lower levels and you're wondering why they're encephalopathic. So that's the important piece there. What we look for in individuals with a hepatic encephalopathy is changes in their sensorium as well as their cognitive function and their neurotransmitter function. Hepatic encephalopathy is usually graded 1 to 4, with 1 being the mild and 4 being essentially comatose. So we look for impaired cognitive function, and individuals with high ammonia levels that are encephalopathic, they have very poor memory. They may be restless, but they certainly, they're very sleepy, difficult to arouse. The asteriskix is due to alterations in those neurotransmitters, so they develop a flap. And they may also, if you did an EEG, would see changes within their brain on neurotransmission. When we think about hepatoencephalopathy, frequently this is preceded by an infection, bleeding someplace in the tract, elevated volume, or remember the liver metabolizes medications. So take a look at their medicine list, because they may be encephalopathic because they're not metabolizing medicines well, and those metabolites or poorly metabolized medicines are either accumulating or the metabolites are causing the encephalopathy because they haven't been detoxed. The fourth complication that we'll talk about is jaundice. Now, jaundice is due to elevated bilirubin levels in the blood, so hyperbilirubinemia. Now, jaundice and this hyperbilirubinemia can be to an obstruction to the bile flow out of the liver or an obstruction to outflow either within or overproduction. So let me say that again, because I think I faltered a little bit. So a jaundice due to hyperbilirubinemia can be due to an obstruction to bile flow out of the liver, an obstruction inside the liver, or because we're overproducing bilirubin. Now remember, bilirubin comes in two general forms. Bilirubin physiologically is either unconjugated, indirect, or it's conjugated direct. Unconjugated or indirect bilirubin has not been changed by the liver. Conjugated or direct bilirubin is unconjugated that has been changed by the liver. So let's look then at the two most common causes of jaundice, which would be some sort of an obstructive process. So we think about obstruction to outflow. When we think about an obstruction to outflow, conjugated bilirubin would be in the urine, but there's none in the stool. So what does this tell you? This tells you that the liver is making it, but it's not leaving the liver. That's why it's not in the stool. So the liver's making it. If the obstruction is inside the liver, as opposed to an outflow obstruction, you'll see both conjugated and unconjugated bilirubin increasing. So the conjugated, they're not excreting. Unconjugated, they're not converting the unconjugated to conjugated. So you can differentiate this jaundice, whether it's an obstruction to outflow or whether the obstruction is inside the liver, by looking at where the conjugated versus unconjugated bilirubin would be. The last thing with the complications of cirrhosis, and this is a very late sign of cirrhosis and causes a great deal of concern. A late sign of liver failure, or late cirrhosis, is the coagulopathy. The production of coagulation factors is usually the last synthetic function that fails in liver failure, because you've lost the synthesis of those clotting factors, especially fibrinogen and factor 7A. So those are the two that you would want to be especially alert for and measure in your labs. The final thing we'll talk about with liver pathologies are in the cirrhosis piece are that non-alcoholic fatty liver disease and biliary cirrhosis. These are two other forms of cirrhosis. So with a non-alcoholic fatty liver disease, remember we started talking this whole thing about the effects of alcohol, and so now let's talk about things that can cause cirrhosis that aren't related to alcohol. With non-alcoholic fatty liver disease, the hepatocytes become infiltrated by primarily the triglycerides. You will see an elevated AST, ALT, and GGT in these patients. This is associated with obesity, with metabolic syndrome and type 2 diabetes, so non-alcoholic fatty liver disease. It does carry a risk of end-stage liver failure, cirrhosis, as well as liver cancer. With a biliary cirrhosis, the process has started in the bile duct and the canaliculi of the liver. Remember, the canaliculi are part of your drainage system. Now, biliary cirrhosis can either be primary or it can be secondary, and these are quite different. A primary biliary cirrhosis is usually an antigen-antibody-mediated destruction. The most common etiology is an autoimmune etiology, and that makes sense. It's antigen-antibody mediated, more likely to occur in women than in men. What we see in these patients is the presence of IgM, as well as anti-nuclear and anti-mitochondrial antibodies. A secondary biliary cirrhosis is very different. This is due to prolonged obstruction of the common bile duct, which then leads to necrosis of the common bile duct and can extend up into the canaliculi. Well, as long as we're talking about a little bit about bile ducts, let's talk about one of the most common liver pathologies, and that is cholelithiasis and cholecystitis. Cholelithiasis is stone disease, gallbladder stone disease, and generally when we talk about gallbladder disease, this is what we're thinking about. With cholelithiasis, the stones are actually made most commonly of cholesterol. Now, they can also be made of pigment, but most of them are made of cholesterol. This is more common in individuals who are obese, more common in women than men, and we also see this in some of the weight loss surgical procedures where they have done a lot of diversion of the GI tract. So what happens in these cholesterol-based stones is you have these supersaturated cholesterol that actually forms crystals. Now, crystals like to get together, and so these crystals actually aggregate, and as they aggregate, they join with mucin. Mucin is a protein-based substance, and with the crystals and this mucin together, this forms a matrix structure inside the gallbladder that then lodges in the cyst, within a cyst, or within the common bile duct. And this is what causes problems, because when you get something stuck in the common bile duct, now you have obstruction to flow. Pigment stones are more likely to be due to a lot of bilirubin in the biliary secretions, and this may also be due to a hemolytic disease, a lot of breakdown of red blood cells, because remember, you can have the release of bilirubin when you do a lot of hemolysis. Now, certainly one of the big things you're going to watch for in the cholelithiasis then, because you've got this common bile duct being obstructed, you're going to see it would manifest as pain. It may manifest as jaundice because you've got the over long term that can happen, but the biggest thing is pain. The other thing that happens is the stone becomes inflamed or causes inflammation of the gallbladder. So cholecystitis is actually the inflammation, and it can be either acute or chronic inflammation, but generally, as we said, due to stone disease. The last thing I wanted to mention about cholelithiasis and cholecystitis is to go back to kids with cystic fibrosis. Individuals with cystic fibrosis, because of that very thick secretion and those mucus secretions that they develop in their exocrine pancreatic function, these secretions can actually cause some blockage of the common bile duct, and or their bile becomes very dehydrated itself, and they develop something that we, for common terminology, we call biliary sludge. And this biliary sludge is very thick, very viscous, and can cause a cholecystitis, and can also, in some cases, cause cholelithiasis. So once again, we've talked about a lot of different things, but we've talked about focusing on the liver in this part of the lecture. We talked a lot about hepatitis and actually ran through some of the labs on hepatitis A versus V to determine someone's immune status or their infection status. We talked a whole lot about cirrhosis and the long-term impact of cirrhosis to liver dysfunction, liver failure, and the complications that could be associated with ongoing cirrhosis. And then we ended with this fairly common pathology of gallbladder disease. I hope this information has been helpful. Please let me know if you have questions. I appreciate your attention.